advise them to shave their chest. This is to ensure we had better electrode contact to the patient's skin. Nonetheless, please also encourage patient to arrive at least half an hour earlier. At the MRI suite, I'm sure we always had this kind of conversation with your patient in order to gain their cooperation and also ensure patient is well ready to undergo the MRI examinations. Good morning, Mr. Hajime. I will be your radiographer today. You may call me Yus. Before we proceed with the exam, I will need to start the MRI safety checklist to ensure you are safe to undergo MRI scan. Then, I will briefly explain the procedure, the do's and don'ts, and what to expect. Let's begin. Ladies and gentlemen, this is the example of patient safety checklist. In the normal checklist, it should cover details as below. Where the patient had any pacemaker device, any artificial heart valve, any prior surgery to patients, any history of shrapnel or metal that has gone into patient body. It will be best to briefly check with patients so that patient conditions are met for MRI scanning, such as if there is any chance of patients being pregnant for the female patients, if the patient suffer from claustrophobia, if patients suffer from asthma or COPD and require inhalers, and last but not least, do patients have any kidney problems? I do believe this standard checklist being used widely in your department. It is necessary to gather all this information and keep it in patient folder for further records. Dear my attentive fellows, before we go any further, I would like to emphasize here that the most common indication for CMR. It can be used for assessment of myocardial function following myocardial infarction. CMR also being used widely for assessment of myocardial viability or hibernation, myocarditis, cardiomyopathies, congenital heart disease, valvular disease, pericardial disease, and of course, myocardial tumor. Of course, just now I mentioned about common indication, but how about things we might need to consider before we put in patient inside MRI? On this list is not a mandatory contraindication, but we rather need to handle this with utmost precautions. We need to ensure do patient have metal implants, pacemaker, and prosthetic heart valve, any claustrophobia experience, and also the patient have any allergy reaction to contrast media priorly. I know this is also will be documented in our previous checklist, but like I said, this is not a mandatory contraindication. In example, the MR compatible pacemaker. With current new protocol, system is able to imaging in selected cases. And lastly, of course, we need to know our table limitation for patient weight. Okay, let's get back to Hajime. Mr. Hajime, we have gone through all the checklists and you are fit to undergo the MRI exam. Let's get going. Of course, the next step is to ask Hajime to change to our hospital gown. While Hajime getting changed to patient gown and to be set with IV lines, let's review equipment that we are going to use. Normally, the equipment that we use and need are ECG electrode, body matrix coil, breathing bellows, unless your system comes with the built-in respiratory sensor, such as in our latest biometric system from Siemens, headphones, and call bell. In this slide, I would also like to emphasize the placing of our ECG for both new and old version of system. On the old version, you might need to use the technique like the top images. And of course, for the new system, you will need to place the ECG according to the lower bottom picture. We need to ensure a very good ECG tracing like in these top images. So how can we define a good electrocardiogram? A good ECG will show us sharp R wave. R wave that is higher than T wave while outside the bore. R wave higher than distortion induced by the magnetic environment while inside the bore. Small baseline distortion, which sometimes can be due to patient respiration pattern and also electrode contact. The tips here is to ensure if we are handling male patient, we need to ask patients to shave their chest area. And for both male and female patients, I will always encourage the radiographer to do skin cleansing using the new prep gel. Nevertheless, a simulation of breathing instruction is a good practice in order to understand which instruction works better to your patient. With this, we will be able to ensure patient can follow the instructions properly during the exam. After we have a good ECG tracing, we shall ensure patient is comfort enough to cooperate with us. We secure the body matrix coil and ensure patient not to move during the exam. And then, let's move him into tunnel and review the scan technique. Normally, when we talk about scan technique in cardiac MR, this is the main topic to be considered. I will briefly bring your attention to morphology, CNE, and delay enhancement sequencing. We will also introduce to you guys the new edition from Siemens. Let's start to look for each topic with the consideration of the reason and where shall we get the sequence from. First topic is morphology. The objective of this sequence is to visualize anatomy and characterize tissue of cardiac muscle and surrounding vessel. In cardiac MR, we will use turbo spin echo technique with possibility of producing T1 and T2 weighted contrast, including fat saturation, which is often helpful for the doctor to make their diagnosis. Here, we can find the sequence tree and do take note, all the sequence will come with dark blood preparation in order to give better visualization with the blood nulling effect. Secondly, the CNE sequence. It will provide us the information of wall motion, which we can use to find any abnormalities, and the function of patient heart valve. With this information, cardiac MR allow us to evaluate the quantitative parameters of cardiac function. In example, ejection fraction, LV mass, and many more. Here you may see where we can get the sequence from. You may find the sequence under function, and most common sequence used is CNE trophy. Ladies and gentlemen, in this next slide, we will discuss on delay enhancement sequence. This sequence will show us an interesting phenomenon, which involving the equilibrium phase after we inject patient with contrast media. Infarcted region will be bright due to shorter T1 compared to a normal myocardium. Here, you may see the TI scout sequence and also common Letget sequence, 3 based on turboflash sequence. Nonetheless, 3 techniques involved in the delay enhancements. 1. Early get. 2. TI scout. And of course, the last one, Letget. Now that you are already understand the objective of cardiac MR and sequence selection, let's see how we can produce a good cardiac planning. In Siemens, we have at least 3 popular techniques to do the planning. Pseudo planning, 3D planning, auto planning with guidance. Let me briefly show to you guys. The first one is known as pseudo planning. Using this technique, the radiographer need to acquire the dedicated localizer like in this sequence tree. In order to get the pseudo to chamber, we shall ensure the planning line is parallel with the patient septum. You need to use thrombus localizer like in these images. Plan the 2-chamber localizer on the axial plane and angle the position line parallel to the interventricular septum. Move the position line to the center of the left ventricle, parallel to the line along the center of the mitral valve and left ventricular apex. In most patients, these structures are not seen in the same image, so scroll through the axial images to spot both structures. Secondly, once you have pseudo 2-chamber, you can start to plan for short axis. Plan the short axis localizer on the 2-chamber localizer and angle the position line perpendicular to the line along the center of mitral valve and left ventricular apex. In other words, ensure it is perpendicular to long axis of left ventricle. With this planning, you will be able to get the pseudo short axis view. Given that we already have pseudo 2-chamber and pseudo short axis, now you are able to plan for your pseudo 4-chamber. Plan the 4-chamber localizer on the two-chamber localizer and angle the position line parallel to the line along the center of the mitral valve and left ventricular apex. Check the position in these two planes. An appropriate angle must be given in the short axis localizer. This is to ensure it is parallel to the line along the right ventricular apex and anterolateral papillary muscle. While planning in the short axis view, please scroll and try to avoid the aorta accordingly in order to get a good pseudo 4-chamber. Next, we can plan the pseudo 3-chamber localizer. Using the short axis localizer, please angle the position line parallel to the line along the center of the aortic valve and left ventricle. Ensure it is perpendicular to the posterolateral left ventricle wall. Check the position in the pseudo 4-chamber also. An appropriate angle must be given in the 4-chamber localizer, which is parallel to the line along the center of the mitral valve and left ventricular apex. Lastly, using the pseudo 3-chamber view, we now can plan the line to parallel to where the aorta and left ventricle meet and prescribe a plane that passes through both of them. This will result in an oblique coronal scalp of the ascending aorta and gives up the left ventricle outflow tract. That is about pseudo planning. Of course, it takes more steps and usually radiographers always need to repeat in order to get better or true cardiac planning once they have proper cine images. Radiographer always need to be more particular while using this technique. The second technique is using 3D planning. In the interest of time, I would like to encourage you all to check this link for better explanation. This is credit to Mr. Julian Gan, one of the senior application specialists in Singapore, which prepared us this interesting topic and technique, including the step-by-step. You may find this information on the Magneton Flash, Volume 72. Tips that I would like to add here is with this technique, we first need to run the no-gap single shot trophy sequence. You may find this sequence from here. Last but not least, in Siemens Healthineer, we always recommend this technique for a young radiographer and high-paced cardiac center. With Siemens unique cardiac engine, user can get auto planning with very minimal user interaction on the system. Let's have a look at this interesting video.
The Cardiac Dot Engine provides many automation functionalities to help you with imaging the heart in MR. These include defining the maximum breath hold time for that patient, the language for auto voice commands, and the dot strategy. The ISO Center Localizer places the heart in the center of the magnetic field. You can get instructions and information in the guidance card to ensure the correct positioning is performed. You can use the Auto-Align Heart to define the measurement orientations of the heart. This will be the basis for all the cardiac plane automatic positioning throughout the examination. From the 5 anatomical points defined in the Auto-Align Heart, the long axis planes are automatically planned. Editing is possible, and the positions of the long axis slices will be used when needed for the entire examination. As in the long axis planning, the short axis planes are defined in the Define SAX step. The number of slices required to cover the left ventricle is automatically planned. Editing is possible if more slices are required. Editing of the order of sequences is possible with simple drag and drop functionality. You can easily monitor exam progress via various visual cues, such as green highlighting and progress timer. Cardiac settings of an opened protocol can be adapted while you are scanning. Simply select the tick boxes of the orientations to be measured and use the quick access to the protocol parameters to update them when needed. You can see what is happening at any point of time. For example, a green protocol is currently running.
The Cardiac.engine harnesses our unique standardization and automation technology to make cardiac scans faster and more robust. For those who would like to review this video again, you may do so by clicking the link given. Take note that the login information is needed to access the PAP Connect platform. Please be informed that this Cardiac.engine will require additional license. Ladies and gentlemen, as we had completed the cine imaging for Mr. Hajime, now let's proceed with the LEDGAT enhancements. As per SCMR recommendations, we shall inject double dose contrast and then wait for 5 minutes delay. While waiting, let's have a look at inline VF result, another features that are coming with Siemens, and this is part of the additional software that Siemens have. Inline ventricular function is one of the functions that Siemens can offer to our customer. It can be activated for cine imaging and calculates left ventricular parameters based on a stack of short axis cine images. By activating it in a long axis cine, it takes into account mitral valve position additionally. With inline VF ventricular function, you can perform fully automatic volumetric assessment, ejection fraction calculation during the scan. The heart is located and the endo and epicardial borders are detected automatically. Data output is right after the image reconstructions without any user interaction. Key to remember, it is a very reliable and fast cardiac volumetric and ejection fraction assessment for a busy and high oriented environment. It is also able to do automatic volumetric assessment and ejection fraction calculation even in patients with cardiomyopathy, dilated and hypertrophic heart, pericardial disease, cardiac tumor, and cardiac transplant. Attached inside this slide is a white paper comparing the inline VF function result versus the manual user contouring. Ladies and gentlemen, let's get back to Mr. Hajime. After contrast injection, it is encouraged to run early GAT sequence. The objective of this sequence is to rule out any thrombus or tumor. The sequence needs to acquire within the first 2 minutes with the inversion time of 400 to 500 milliseconds. Normally, it will consist of long axis view only. Before we jump from early GAT to late GAT enhancements, I would like to emphasize the needs of the iSCALP sequence. The contrast between tissue in an inversion recovery pulse sequence is strongly dependent on the TI value chosen. Selecting a TI value where a tissue passes through zero effectively nulls that tissue in the image, rendering it dark. To determine the proper inversion time in order to null normal myocardium, an inversion time mapping sequence is frequently performed. This method is based on a principle developed by Luke and Locker used in the 1970s. When applied to modern MRI, it is known as the iSCALP. The technique consists of a centric ordered, segmented series of cine gradient echo, which will be obtained over 2 to 3 heartbeats, with each segment corresponding to a different TI value. The series of reconstructed images is visually evaluated to select the best TI for optimal myocardium nulling, and with that TI info, we will run the late enhancement sequence. Here you may get the TI SCALP sequence. The next technique of the scan, of course, delay enhancements. Due to the delay of contrast injection, during the equilibrium phase, an interesting phenomenon happens, so-called late enhancements will be occurs. Both normal and diseased myocardium will take up gadolinium contrast and exhibit enhancements. The rate of gadolinium accumulation and washout depends on multiple factors. This is including present or type of heart disease, myocardial blood supply, heart rate, hematocrit, and renal function. Many diseases result in myocardial fibrosis with expansion of the extracellular compartment. In these delay phases, gadolinium washes out of a normal tissue but is retained by pathologic one. In myocardial infarction, for example, both uptake and washout are slow, so late enhancement is characteristic. This is sometimes called hyperenhancement. Do take note, late enhancement patterns do not only appear in the case of infarction, but also in a rather specific way in a variety of other cardiac diseases. Here you may get the sequence, and commonly the technique is based on turbo flash sequence. Alright, now it is already 5 minutes. With the predetermined TI value from our previous TI scout, let's get back to Mr. Hajime. After the TI scout sequence, Mr. Hajime squeezed the call bell and told us that he is unable to hold the breath sufficiently for the lead cat. There's only 2 slides able to capture as above. In this exam, we are unable to deploy our standard high-res technique. So, shall we stop? Like I mentioned to you previously, delay enhancement sequence is rather important information for the doctor to do their diagnosis. Some people even say that this is where the money value in cardiac MR. Worry not, in Siemens, we still can offer you some workaround. Instead of keep trying with the standard high-res sequence, we can manipulate and change our approach to single shot IR trophy technique. Using this sequence, we can achieve a good resolution images even for patients with no breath hold capability. This sequence also very stable and a good choice for the first coverage of whole heart. We also encourage to cover the interesting region, left ventricle in this case, with single shot technique, and please also run at least in 2 different orientations. This is where you might find the protocol. And as for Mr. Hajime, with this workaround, doctor decided that this is enough information on his delay enhancement sequence. Ladies and gentlemen, now we shall proceed on the post-processing and also result. Early on, we look at inline VF. But if the option is not available, we shall proceed with the next post-processing technique. In Siemens, our post-processing allows you to see immediate result when you open your case under the MR cardiac analysis. It will give us inside information of LV analysis result and qualitative delay enhancement result. Using this feature of MR cardiac analysis, you will get instant display of pre-processed auto-segmentation of left ventricle, which is based on price-winning algorithm. You may also get the automatic calculation of ventricular volume, ejection fraction, and myocardial mass. Automatic calculation of myocardial thickening for all myocardial segments following the AHA segmentation. Semi-automatic post-processing of the right ventricle, dynamic evaluation such as time volume diagrams, filling rate, and myocardial wall motions, integrated and synchronized movie display, graphical display of results such as table, bullseye plot, 4D model of the heart, and integration of the result in a report for documentation. In summary, with MR cardiac analysis, especially for left ventricle, user will get auto-contouring with base plane correction on long axis within their finger. For further info on this, please visit the link given. Lastly, using the delay enhancements, doctor will be able to localize and determine the pathology area accordingly. With all of this information, it brings us to the last step, which we already completed, the viability study. It is the end of our examination. We must ensure patient is okay, and all our images been sent to reporting doctor. We have completed the scan, Mr. Hajime. I will remove the IV line and get you changed. You may return to the clinic while we get your MRI report ready for your doctor. While the radiologist is reporting Mr. Hajime images, let's review new technique available from Siemens. We all know we had some challenges, especially in order to characterize and quantify tissue changes. With conventional delay enhancement, we still had difficulty to detect non-localized and diffuse tissue changes using only qualitative data. Building that in mind, we at Siemens Healthineer would like to introduce you with MyoMaps. Let's have a look at this short video. Please be informed, with MyoMaps, you will get on-the-fly quantitative maps without the need of any user interactions. MyoMaps will give us information in the shape of relaxation time mapping, which will broaden our possibility in characterize tissue changes. Another challenge is on net-gate enhancements. Previously, we introduced you the workaround of single-shot IR through-face technique. Almost all the time, patients will suffer and complain that they are unable to follow the breathing instructions anymore. So end up, your images will be something like in this slide. Rest assured, with the latest Siemens technology, we can offer you a solution of heart freeze software. Heart freeze comes with motion compensation algorithm, which will bring the benefit in acquiring high-resolution images in a free breathing. And at the same time, hospitals are able to extend their cardiac MR services to even more patients. This is including pediatric and geriatric patients which cannot hold their breath, and of course, it's also advantage to the arrhythmia patient. For your information, the minimum level of your system software need to be on XA platform. Now, MR report is ready. Let's follow up Mr. Hajime at Sarina's clinic. Thank you for listening and good day. Sehingga berjumpa lagi dari Malaysia. Kasih.
The multiparametric nature of cardiac MRI can provide comprehensive assessment in patients with known or suspected coronary artery disease. Its ability to directly assess myopathies and its extent often contributes insights that can change the patient's management. Unfortunately, the lengthy duration of the procedure and the narrow design of the gantry make it challenging for some patients to tolerate the procedure. Also, those with metallic implants or pacemaker may not be suitable for cardiac MRI. CMR is complex. It is not a single technique. Instead, it consists of multiple distinct techniques and a lack of understanding of which techniques to perform and how to interpret the findings limits its widespread use. For this, a different imaging modality may be considered. Let's see how molecular imaging can be used to further evaluate the extent of Mr. Hajime's condition and how it can be performed.
Hello everyone, my name is Adrian Luigi Morte, Clinical Application Specialist for CT and MI from the Philippines. Today, we will discuss one of the most important diagnostic tools in the assessment of coronary artery disease available in nuclear medicine. This is myocardial perfusion and viability. While other diagnostic imaging modalities offer structural and morphological information, molecular imaging provides functional images to assess coronary artery disease. It provides information on the extent and severity of myocardial perfusion abnormalities, including ischemia, left ventricle size and function, and mechanical dysynchrony. At the end of this learning activity, participants will be able to understand the role of molecular imaging in diagnosis of CAD, differentiate myocardial perfusion from viability, identify the different radiopharmaceuticals in nuclear cardiology, demonstrate scanning and reconstruction techniques, and finally, evaluate myocardial status based on scintigraphic images and patterns. Myocardial perfusion imaging. A diagnostic study used to evaluate myocardial perfusion and function to detect physiologic and anatomic abnormalities of the heart. It portrays images of blood flow to the heart muscles. This is done by first injecting a radiopharmaceutical. So the radiopharmaceutical will be administered to the patient intravenously, delivering the radiopharmaceutical to the systemic circulation, finally reaching or perfusing to the myocardium via the coronary arteries. So once delivered, a viable metabolically active myocardium must be present to extract the injected radiotracer or the radiopharmaceutical. Finally, using our diagnostic imaging modality in nuclear medicine, which is the gamma camera, scintigraphic images will map regional perfusion or blood flow. So as you can see here in the image, this is an image of the left ventricle myocardium that successfully extracted the radiotracer because of two primary reasons. Number one, because the coronary arteries is patent, and number two, because the heart muscle or the myocardium is viable enough to extract the radiotracer. However, if a patient has CAD or coronary artery disease or loss of cell viability as a result of infarction, a perfusion defect or cold spot or cold region is seen on the images. Referring again in this image, when a patient has CAD, some areas of the myocardium of the left ventricle will not receive the radiotracer or the radiopharmaceutical injected. Hence, this is again, we call it the cold spot. As for the indications, MPI scan will be ordered to patients to the following purposes. Number one, detection of obstructive CAD and define the number location and significance of coronary artery stenosis, risk stratification of patients and to provide prognostic information, assessment of myocardial viability, to provide guidance on medical therapy and monitoring of treatment effect after vascularization procedures. However, for some patients, this procedure is contraindicated. Number 1, recent ingestion of contrast media. Number 2, radionuclide study performed within 48 hours. Number 3, patients with severe arrhythmia or irregular heartbeat. And finally, a patient who is pregnant or is lactating. Next is patient and scan preparation. Patient should fast for 4 hours. Patient should not consume any amounts of caffeine 24 hours prior to the procedure. Patient should not smoke 24 hours prior to the procedure. Upon approval of the referring physician, patient should discontinue medications. Example is beta blockers. Beta blockers may prevent the achievement of heart rate necessary for a successful stress test. Next is nitrates and calcium channel antagonists, which can possibly mask underlying ischemia. Lastly, patients should be well rested and avoid strenuous activities. Now, let me demonstrate a step-by-step guide on how to perform myocardial perfusion imaging scan. First step is administration of radiopharmaceutical. A radiopharmaceutical is a combination of two components. The first one is a radionuclide. A radionuclide emits gamma rays, which is necessary for image formation. The other component is the biologically active molecule or the pharmaceutical, which serves as the carrier. So let us have an example. For our radionuclide, we have technetium-99m. Technetium-99m is the most common radionuclide in nuclear medicine imaging. It has a half-life of 6 hours and an average energy of 140 kiloelectron volts. For our pharmaceutical, we take Sestamib as our example. Sestamib, when injected into the patient, will always localize into the heart muscles or the myocardium. So altogether, we have technetium-99m and Sestamib as our pharmaceutical. We call it technetium-99m Sestamib. As mentioned earlier, this radiopharmaceutical shall be injected or administered intravenously to be able to deliver it to the myocardium. There are two major radiopharmaceutical for this procedure, myocardial perfusion imaging. These are technetium-99m Sestamib, which is taken up by the myocardium according to regional myocardial perfusion. The adult dose is in the range of 15 to 30 MCI, and usually we administer it by 2 doses. The first dose is injected before the rest scan, and the rest scan will be performed or the patient will wait for 45 minutes to 1 hour before the imaging. The next dose will be administered after a successful stress test. After a successful stress test, the patient will now be scanned in the gamma camera after 30 minutes. The next radiopharmaceutical is thallium-201 chloride. Aside from thallium-201 chloride as being a perfusion agent, it is also special in a sense that it can assess myocardial viability because of its property of redistribution. The adult dose is in the range of 74 to 148 megabecquerel or 2 to 4 MCI. And unlike with sestamib, we only give one dose of thallium 201 chloride to our patients. And this is usually given during a successful stress test. After a successful stress test, we will scan the patients within 15 minutes post-injection of thallium 201 chloride. And after 3 to 4 hours, we will commence with our rest scan. As preferred by the cardiologist, it may be necessary to perform a 24-hour delayed scan for certain purposes. The next step is to perform a stress test. So why is this necessary? By increasing cardiac work, the demand for oxygen and thus blood flow increases. In response, the coronary arteries vasodilates. If the patient has stenosis or coronary artery disease, vasodilation will be limited. As mentioned in the preceding slide, the radiopharmaceutical shall be administered, but only after a successful stress test, the radiopharmaceutical will be administered. So what do I mean by a successful stress test? The patient may run on the treadmill and must reach at least 85% of the age predicted maximum predicted heart rate. So after the achievement of this minimum requirement of 85%, the radiopharmaceutical can be administered intravenously. So a stress test procedure can be performed in two ways. Again, number one is physical. The patient may run on the treadmill. And again, the goal of the patient is to reach at least 85% of the maximum heart rate requirement. If for some reasons or for some conditions of the patient could not run on the treadmill, we can opt for a pharmacologic way of stress test. So in the pharmacologic way of stress test, we administer drugs that mimic vasodilation and increase heart rate. The first on our list is dipyridamole. Dipyridamole is infused by the following parameters: 0.14 milligram per kilogram per minute for about 4 minutes. So when infused, please note that aminophylline should be at hand to reverse significant side effects such as asthma, since dipyridamole is a vasodilator drug, which can also vasodilate the bronchi. If patients are asthmatic, it can worsen their condition. Next on our list is the butamine. The butamine is injected 5 to 10 millicentigram per kilogram per ml over 3-minute increments, rising to 5 to 10 millicentigram per step until the 85% of the maximum heart rate is reached. So this is like injecting a drug, and the patient will experience a significant increase in his or her heart rate. And when the patient reached at least 85% of the maximum heart rate, we can now administer the radiopharmaceutical. Last on our list is adenosine, which has an infusion rate of 0.14 milligram per kilogram per minute for about 6 minutes. So again, we can opt to use pharmacologic drugs or stressors which can mimic the vasodilation and also the increase in heart rate of the patient when the patient could not run in the treadmill. So how do we perform a stress test? To perform a stress test, the first step is to place the 10 electrodes on the patient's chest and hook the ECG monitor. Refer to the first image on the correct placement of the 10 electrodes in the patient's chest. Second step is to monitor the blood pressure in sitting and standing position. Third step is to start the treadmill using the modified Bruce protocol. Fourth step is to take blood pressure and ECG every 3 minutes of each stage of the modified Bruce protocol. Then inject the radiotracer at peak exercise. Again, this is the goal of the patient, to reach at least 85% of the max heart rate. Finally, let the patient recover and start the stress scan within 15 minutes. Following a successful stress test, and that we already administered our radiopharmaceutical, thallium-201 chloride, we can now perform our first scan. This is the stress scan. The stress scan will follow the following parameters in this protocol. First one is the collimator. So if we are using technetium 99M as our radionuclide, we need to install low energy, high resolution collimators. But since we administered thallium-201 chloride, we need to install low energy, all-purpose collimators. Next, the gamma camera heads will collect information from the patient's heart at a gated TOMO acquisition. Gated meaning that the ECG are connected into the patient's chest to be able to collect information of the patient's heart free from motion. Each detector will be at a 90-degree configuration with one another, and the gamma camera heads will rotate towards the left side of the patient where the heart is at 180-degree angle. 40 seconds per view, and a total of 32 views will be collected from our patient. If CT is available, as with our hybrid scanner, SPECS CT, we can perform CT for the purposes of attenuation correction. But, for example, if CT is unavailable, we can scan the patient in prone. So, how do we perform the stress scan on our actual patient? So again, we need to configure our detector heads to be at 90 degrees with one another. Within 15 minutes, we position the patient supine in the scanning bed. We position the patient's arm over his head using this accessory. We put the electrodes on the patient's chest and hook the ECG to facilitate the gated acquisition. We move the bed towards the detectors, locate the heart, and position the detectors as close as possible to the patient. Of course, we instruct the patient to refrain from moving during scanning. And again, for reference, this is the correct position of the electrodes in the patient's chest. Then, we acquire and let the machine do its job, collecting 180-degree projection towards the left side of the patient. our patient to return 3 to 4 hours post-injection of our radiopharmaceutical, which means that the heart at this state is well rested. So basically, this is the same procedure we performed in our stress scan procedure. Again, we position the patient supine in the scanning bed, arms over his head. We put electrodes to be able to facilitate gated tomo acquisition. And we move the bed towards the detector. Again, locate the heart, position the detectors as close as possible to the patient, and instruct the patient to refrain from moving. As mentioned in the previous slides, CT can be performed alongside with our myocardial perfusion imaging procedure. This is for the purposes of attenuation correction. The effects of soft tissue attenuation can be seen on most cardiac images and worse with large patients. For example, males have decreased activity in the inferior wall called diaphragmatic attenuation. Among females, relative decreased activity in the anterior wall, apex, and anterolateral portion secondary to breast attenuation. So for this scenario or instances, CT can be helpful in minimizing attenuation artifacts. Aside from this, CT can be used for coronary artery calcium scoring, and eventually we can also use CT for coronary artery angiography or CTA. This CTA data or images can be fused with our SPECT studies to be able to create an overlay of the anatomy and physiology of the heart muscle. So with CT, this gives us additional diagnostic information on the morphology of the coronary arteries supplying blood to the myocardium. And again, for SPECT or in myocardial perfusion SPECT, in molecular imaging, which gives us functional data on how well the blood is perfused in the myocardium. So we have both anatomy and physiology as our data in this fusion. After successful acquisition and processing of our SPECT datasets from stress and rest images, I will now present the myocardium in its three-dimensional orientation. So this is a normal image of the myocardium performed under myocardial perfusion imaging. The first orientation is the short axis view, which divides the slices from apex to base of the heart. So the scintigraphic images looks like this. And as you can see, there is two data sets compared with one another. These are the stress and rest images. Next is the vertical long axis. So we divide the myocardium into left and right portions. So basically, this the scintigraphic images looks like this, wherein the apex is here and the base is in this side. The anterior portion and the inferior portion of the left ventricle myocardium. Finally, for our last view is the horizontal long axis, which divides the myocardium into superior and inferior portion. The scintigraphic images looks like this. So again, this is a normal myocardial perfusion imaging scan. For the image interpretation, again, we compare rest and stress datasets. That, for example, if a defect or a cold spot is seen in stress but not in rest, we can say that the myocardium is ischemic, or we refer this as myocardial ischemia. This is a reversible defect, which means the patient can benefit for a revascularization procedure. For example, a percutaneous coronary intervention. In another scenario that we see a defect or a cold spot in both stress and rest, the myocardium is said to be infarcted, or this is a dead muscle tissue, or what we know as myocardial infarction. This is an irreversible fixed defect, which means the patient will not benefit to a revascularization procedure. So in summary, in this table, again, only if we see a cold spot in stress, but the rest is normal, again, the term is ischemia. But if we see both cold spot in rest and stress, this is a myocardial infarction. Then previously, I showed you the three orientations of the myocardium when we performed our SPECT acquisition or gated gamma acquisition. So again, here we have the short axis view of the heart, and labeled for each segment is the supplying coronary arteries involved. That, for example, in both the septal or an anterior portion of the myocardium, the left anterior descending artery supplies blood in this area. For the inferior portion of the myocardium, the right coronary artery supplies blood in this area. And in the lateral portion, the left circumflex artery supplies blood in this area. So what does this mean? So if, for example, we see a defect or a cold spot in the anterior portion of the myocardium, it may mean that the coronary artery left anterior descending, LAD, is obstructed, or there is stenosis in that area because there is no perfusion or cold spot seen in this region. So basically, we can have information on what coronary arteries is involved because of the cold spot or a defect seen in each portion. We can also cross-check this with other views, again with our horizontal long axis and vertical long axis images. And again, for your references, these are the LV walls and supply arteries for apical, septal, anterior, lateral, and inferior portion of the myocardium, and their corresponding coronary arteries that is supplying blood to this area. So here in this slide is an example of a myocardial infarction, which matches a defect in both stress and rest image. So again, this is the short axis view of the heart, and the defect in stress for example here, corresponds to the defect in rest here in this inferior portion. So we can diagnose that this is a myocardial infarction. Now that we have discussed myocardial perfusion imaging, in which we describe the myocardium as myocardial ischemia or a reversible defect. And patients with this condition can benefit from the revascularization procedure, such as percutaneous coronary intervention. On the other hand, we also describe the myocardium as being infarcted or myocardial infarction, which is an irreversible defect. And patients with this condition will not benefit from the revascularization procedure. Although this is the case, 20% of patients with these findings do not have infarction, but rather severe chronic ischemia or hibernating myocardium. So with this, we will now discuss the myocardial viability, which checks or gives an opportunity for our patients with myocardial infarction to be able to become a possible candidate for revascularization procedure, provided that their myocardium is still viable. Myocardial viability. Viability refers to the myocytes that have preserved cell membrane integrity and sufficient metabolic activity to maintain cellular viability, but not contractility. Patients with viable but hypoperfused myocardium can benefit from coronary revascularization. Again, an example is percutaneous coronary intervention. So for a patient to be subjected with this kind of procedure, the doctor may be ruling out a hibernating myocardium, a chronic ischemia with decreased blood flow and downregulation of contractility. And again, this is reversible with restoration of blood flow. As discussed earlier, thallium-201 chloride is one of the radiopharmaceuticals for myocardial perfusion imaging. Aside from this, thallium-201 chloride is used for the assessment of myocardial viability. In this regard, we will now discuss myocardial viability protocols available in our thallium-201 chloride radiopharmaceutical. The first one is thallium-201 late redistribution. Imaging beyond 3 hours for delayed redistribution. This is usually an additional scan 24 hours after the radiopharmaceutical administration. The rationale behind this is that severely ischemic myocardium with slow and uptake clearance requires more time to redistribute. The second protocol is a restless thallium-201 redistribution for patients with known coronary artery disease, prior myocardial infarction, and ventricular dysfunction. This justifies the need for a revascularization procedure. REST-1 includes images obtained at 15 minutes and REST-2 includes images obtained after 3 to 4 hours. So, regardless of these two protocols, even if the patient has been diagnosed with myocardial infarction in their myocardial perfusion scan, provided that the thallium-201 myocardial viability is successful, they have the chance to benefit from our revascularization procedure. So for our demonstration, we selected the thallium-201 late redistribution protocol, in which, again, we have the stress, rest, and thallium-201 24-hour delayed scan. So to process these images, we select all of our data sets and click on the designated workflow to process these datasets. So in our data selector, we ensure that the workflow inputs contains the datasets stress, rest, and thallium-201 24-hour delayed. In the quality control, we check for any motion artifact. So if we found out motion artifact in any of these datasets, we can apply motion correction, or better, we rescan the patients. The next step is the auto recon. So in the auto recon, we apply reconstruction algorithm. We can apply either an OSEM 2D or a Flash 3D. And we ensure that each dataset is constrained in our ROI, or in that yellow region as you can see in the screen. We also check for the gated slices and images. Next, we click on the reconstruction tab. So same procedure, the yellow ROI must contain the myocardium. And for